Okay. All right. So hopefully this will do. Usually you could just change devices, but some reason it was not letting me change devices. So again, put your name and campus in this one again. Wow. Oh, y'all can't hear me. This thing is on mute. Okay. All right. So good evening to everyone again. Place your name and campus in the chat again, because this is a new link here. It wouldn't just let me add the other device in. It usually does, but not sure. But nevertheless, let's just move on with this new recording here. Give everybody time to get in. Hope everybody's doing well. We got everybody. Looks like we're missing about two. Give them just a little moment to sign on in. So as always, you all, you have to be on camera. In the event that you're not on camera, that you have to walk away for like a short moment of time, you put a message in the chat to myself. You make sure that you're there so that they can see you all. These sessions are, they're recorded and they can be viewed by the attendance administrators. All right, I think those our last two are coming in now. Good, good, good. All right, I think we have everyone. Good evening again. Hopefully I don't lose connectivity, but if I do, just stay right there. I'll give you some instructions. But nevertheless, let's move on. Let's get started for this week. So you finished one exam. So let me just hear from you. What do you think about the exam, the content, and you don't have to share if you don't want to. Your understanding of the content and everything. What do you think? That next gen is in there, that drag and drop. It's a mix of things. How do you feel about it? Okay, hearing none. So you all did really well overall. So let's just press it. Let's just go even further. So those things that you have done that you found out that helps you stick with those things. And there's some other techniques, and I drop them in along the way. Hey, test taking tips. And so just add in whatever else. But for sure, going back, looking at our classroom recordings, making sure that if you cannot attend the exam reviews, that you are actually taking the time to go back through them, but just make sure that you are doing those things that have helped you to be successful, because you all have done really, really, really good. So that's good. So pat yourselves on the back. One down and what, three more to go, two more unit exams, and then the of course the HESI. So, and like I said, all of us can stand for room for improvement. So just also think about what you can do differently. If you did the group this time, maybe the group studying may not be for you. You may not need to do the group study and that's it. You may have to still pull to the side and do your own, but you figure out what works for you. So you're right here at this end. So just like I say, just don't let up on what you found that works. Continue with that, but you may add some additional tools to your toolkit as we go along. So don't forget, you do have those adaptive quizzes that are coming up. So just making sure that you have the seat time, because every point matters when you sit down to take those adaptive quizzes. So let me just share my screen here. Let's see. We are in week 4. And let's see where we are going. Share. Okay. So week 4 here, we're going to be talking about all different types of communication. Just let you look at that for just a okay. So we're going to be talking about all different types of communication, because remember I said last week, you all are in that middle and everybody's coming to you, even though we have all of these people on the healthcare team. And we're going to talk about some of those, start talking about some of those as well. We know the nurse, we can work in different settings. We're going to be talking about the respiratory therapist, the physical therapist, all those others, dietitians. And then how are we actually communicating, interacting. You see the word collaboration a lot. Collaboration And then types of communication. How we communicate. Should we rephrase what we're getting ready to say? How can we phrase it so that it doesn't come off as aggressive and so that we are not limiting our conversations and our patients from giving us the information that we need. And also, we're not hindering the communication and the care that our patients will receive. So that communication, it seems like it's a small thing, but it's a huge piece. You do have your lessons, and then you have your adaptive quizzes. And then next week, we'll look at more of those that are on the team. And then we're going to look more at that leadership. We're going to start talking about that delegation. Now, students in the past, they have said delegation is huge on your HESIs. So just making sure when we talk about that you have those rights, you got them down, you know what the rights are, and then you go from there when we're talking about delegation. And then our next thing would be, of course, you have another lesson in adaptive quiz. And all of these things, they should, what the research is showing, that we've trended to this. We've been doing these lessons, these adaptive quizzes now for like, has it been 2 years? May not been quite 2 years, but students' performance, their NCLEX scores, and so it's a method to these different lessons and adaptive quizzes. So just making sure that you actually embrace them and complete them fully, because there's a connection with that, with your unit exams, with your HESIs, and then for sure with your NCLEX. And then again, an exam in unit exam 2 will be week 6. So we meet today, we meet next week, and then we have your next exam. So for sure by the week, I know I said this in week 1, you all, week 11 will look different for you. Remember, it will look different for you. This class meets kind of late. So now, unless they change up things, your HESIs, this is just for all of your classes, is campus specific. So no matter what Miss Harrison is doing and Miss Lee is doing, you need to know what they're doing at your campus for each of your classes. Because, and you all know this, just because you have a class that's on a Monday or Tuesday, your HESI might be 8 a.m. on a Friday. So just keep that in mind. Your week 11 is going to look a little bit different. So just keep that in mind, pencil that in, because, you do have all your responsibilities, work, family, and everything. So I just like to just keep reminding you of that. All right. So let's transition here. And these are the same PowerPoints, you all, that you have. I just like to piece them out, pull them together, and add some different pictures and things to them. I guess maybe I'm a visual person. I think I said that the other day. But so we're going to go through your PowerPoints here. And to me, some of the slides that they generate have a lot of information on them, which mines are kind of full too, but I kind of like piece it out. And that's what you'll have to do once you're reading and studying your your content. Make it work for you, especially if you have those PowerPoints. If you like a certain color or if a certain color standing out to you, you can highlight your slides and click the little thing and it changes all your slides to a certain color. If that helps you learn best. I know people have used blue ink, I'm just throwing out some test taking things, and so that you can understand the material, the concepts, because if you understand what the concept is, no matter how the scenario is presented to you, you'll be able to answer it correctly. All right, so here we go. Healthcare professionals are life learners, you all. This is what you're signed up for. Most of you are working in the healthcare field already. And there's an in-service, sometimes they call them different things. There's a workplace evaluation. Sometimes it's every 30 days, every 60 days, every year, but it's ongoing. It never stops. It never stops because, we want to provide the latest evidence best care anyway. So we look for it. But, one thing, the hand washing thing, it hasn't changed, you all. You have to have that friction for that certain amount of time. But nevertheless, there's so many upgrades and equipment. I just think about how we were checking blood pressures. Manual was the only way to go. Then all of a sudden they had this automatic thing. Now you have this device that rides around, and you have the blood pressure, you have everything. You can check the respirations, you check all of it with this one device. So, but nevertheless, competence should be continuously evaluated. That's our competence, showing that, hey, this nurse, we are good. We are good on providing this best care for this client. So it's continuously evaluated. And I just listed some workplace evaluations, just gave some example of how it's continuously evaluated and improved to ensure high quality, that best care is being provided, the latest evidence, the care plans, the interventions are patient specific. So it is the best care, high quality care for our patients. So we need to know it's continuously, it is high quality. So how do we do that? We have these evaluations. And once you get your license, and some of you all have already have like that, those other certifications, and you have to have so many units in order to renew and renew. So continuing education units is an example of what states require. That's what they call those units. Each state will tell you how many you need, but nevertheless, it is continuously. And why are we needing to continuously improve upon our competence so that we can provide that best care for our clients? Okay. So a huge piece of this, like I said, we'll spend most of this time talking about communication. Needs to be clear, and we have to be able to work well with others. You know, we're that central pod. Yes, you have the doctor, you have the nurse practitioners, you have the physical therapist, the dietitian, but guess what? All of them more than likely are going to be able be communicating with you. You're going to be that main hub. So we have to be able to communicate clearly. And then also when things are being communicated to us that are not clear or there's some misunderstanding, we want to clarify. So we're going to talk about ways that we can clarify that, because that we need clear communication, and we have to also be able to work well on a team, because it's just not that one person. It's not just the nurse that's taking care of the patient, but everybody's going to be coming to that nurse for questions and answers. So as healthcare professionals, we encourage open communication. It allows for the parties to express their concerns and work towards a resolution, a solution. We talked about open-ended questions, closed-ended questions. So we do want to encourage that communication. Early on, we said establishing therapeutic communication is key in us providing the best care for our clients anyways, because the clients will let us know what's going on with them. They'll be more forthcoming with information and everything. So and we want to encourage open communication. And this allows for the patient to express, hey, even if they don't like her intervention, hey, I understand you say this is the best thing. The doctor is saying this is the best thing for me, but I want an alternative. Or I don't want this intervention. So that open communication allows for that client to express what they need. And on the end, when the client's discharged, when you are no longer taking care of that client, it lessens the chance for recoil or backlash. Well, I told that I really didn't want that done, and they gave me that medicine, even down to their medications. The clients have the right to refuse. And the right to refuse is a part of open communication. So if they ask what that is that they're taking and what is it for, well, hey, I don't want that. That we want that open communication. So I want you all, we're going to use the chat for this one right here. So first off, I'll give you a minute. Let me get my timer pulled up. Care coordination. 2 words. In a sentence, what do you, if you were explaining to someone what that is or what it entails, who's involved, a one-liner. I'm a clock here. In the chat, everyone respond. You are telling us about care coordination. And I'm going to put a timer on. Give you a minute here. Care coordination. Okay. If you go on mute so you can think about it. Care coordination. And send it out so everyone can see it, even though you are going to be more than likely saying almost the same thing. Remember, the more times we see things, we automatically create this remembrance of it and understand it. Let me stop sharing.
You're muted.
Miss Ford, we cannot hear you.
Oh, thank you. I was let me turn off our timer here. I was looking at your comments and I was saying that Miss Carter placed, she said providers. She has an S on it. So that's good. Francis said physicians because they have that healthcare provider, the main person, but then there are so many times like the dentist is not the same person as the healthcare provider. The foot doctor, the podiatrist, the oncologist. So yes, we have to think about all of that. And then you all use that word collaboration. Wow. And then thinking about safety, coming together. Yes. So be sure that you all are looking at what others are placing in the chat because it's huge in being able to coordinate and provide that best care, that latest best care for your clients. So yes, you all were spot on. Okay. So care coordination, I may need to change this slide because it can't hardly see it, but I'll make sure I read everything. Care coordination. I got too fancy with my slides. Care coordination is recognized as a professional standard and essential competency. It is fundamental in improving the quality of care delivery while reducing inappropriate use of healthcare services. So it could be inappropriate if a client does not go, they don't go to see all of their healthcare providers. The patient is supposed to see the dentist today, but their doctor's making rounds today. That's inappropriate if that patient does not get a chance to see both providers. So we have to think it through, collaborate, coordinate, think it through so that these patients can be seen. But what about the patient? You have a doctor coming in, and I don't know if you all have seen this, especially in the long-term care facilities. The dentists, they come in, the foot doctors, they come in, the eye doctors even come in. But you have those patients, some that they call bed bound, that they only get up in the event there's an emergency, and and even then they pull them out in their beds. So do these patients not get seen by the healthcare provider? No. So we have that conversation. The nurse is talking to the doctor. Hey, we've seen everybody, but we have two patients in our facility. They're supposed to receive care from you. Supposed to get the teeth cleaned today. They're supposed to get whatever it is, but we need you to go to their room. So you have to take that set up clinic and make that patient space to as a setup clinic inside of their room so they can still receive those services. Is that talking, that clear communication when that doctor comes in, or even before they come? Because a lot of times what they do is they get their numbers or their list a couple of days or weeks before, and already communicating. The nurse is communicating prior to that doctor arriving. Hey, we have these two patients. We're going to need you to go to their room and provide, to pull their teeth or to cut their toenails or whatever. That is communication, clear communication, and it is coordinating and collaborating. So care coordination organizes care and information around the patient's needs and their preferences. So what if the doctor goes, you have a patient that goes down to see the dentist and they say, hey, the dentist says, we recommend pulling this tooth. The patient has the right to refuse. The patient wants dentures. And right now, they still have most of their teeth. So after talking to the dentist and their healthcare provider, because, they do have things that they have to check off on as well. Like they want certain labs done and things like that. They want to look at immunizations, but they'll have that checklist. And but they have to decide is what the whole point of the story is, coordinating that care. So this patient still has some of their teeth. So we'll have to coordinate a visit. Can this patient go to the dentist actual office and get some of these teeth pulled in preparation to receive these dentures that they want? So it all there'd be all different types of stories, but the whole point of it is we have to coordinate that care. We have to be talking. There it might be several conversations that may have to be had, but nevertheless, care coordination is essential for improving quality of care and reducing healthcare costs. The patient that needs to see the dentist and their healthcare provider, coordinating those appointments so that the patient can see both is going to lessen that person. Well, I think I got this on the slide, so I'm not going to say that part, but I'm just going to read this right here. Care coordination is essential for improving quality of care and reducing healthcare costs. Like, what does that really mean? Think about that. If we have this patient, they're going to see their physical therapist, they're seeing the foot doctor, all of these people, they're following up with their ortho. How does that reduce healthcare costs? So just think about that for a moment. So care coordination is one of the six priorities identified by the National Quality Strategy for providing more affordable, improved, and patient-centered care. It's all about that patient. Yes, we have NANDA, we have all these nice and bright interventions, but is this patient-centered? Is this what's best for this patient? The Patient Protection and the Affordability Care Act identifies care coordination as a key. Listen up, you all, in shifting towards value-based care delivery models. So, what is this value-based? We need to know this value-based. And so, just think about the word value. Is this patient coming back? Are they having recurrent UTIs? Is this patient having readmissions? And not just readmissions, but are they being readmitted for the same um, diagnosis? This person having recurrent UTIs, have we not found out, you know, their water? Do we need to increase their water? Do we need to add in? Do we have all these different supplements and things? So it changed to value based. So you might be on that team, and you may have seen some of the nurses in facilities where they are on that quality team or value based team. They don't Their name tags don't exactly say that, but that's what it is. They're going around, they're collecting information. How many UTIs have we had? How many readmissions have we had? And are these readmissions for the same thing? Because they want to put everything towards value based. Hey, let's just stop for a moment. Let's figure out what is best for this patient rather than, they have the algorithms that they follow, but every now and then the algorithm that meet this patient specific or patient centered need. So let's change it. Let's address it. Effective care coordination helps prevent fragmented service delivery, cost inefficiencies, and poor health outcomes. It is important for everyone, not just those with chronic conditions, as all individuals may need improved coordination at some point. That's a little time. So just no matter if this client, this patient in room 201, they may just have diabetes. They might not have hypertension. They may not have, whatever it is, but still, what does this client need so that this client can receive everything from A to Z that this patient needs so that they can reach that optimal level of care. And if we're like teaching them to go home and take care of themselves, and if we're going in as a home health client, do they have the medical supplies? Do they have the equipment? It's a lot. This coordination, you all, is several moving parts. So effective collaboration is an interdisciplinary team. And this is everybody on there. PT, dietitian, respiratory, you unlicensed personnel, the nurse, the anesthesiologist, everybody involves active listening. So we were talking about this earlier, about this listening thing. So active listening includes us conveying to the patient, hey, I am here for you. I'm here. I have your best interests at heart. I want the best care for you. Active listening also includes picking up on those things your patients are not saying verbally. So looking at those nonverbal cues, asking those more focused questions when they have a certain response. So active listening is huge and sharing relevant patient information. This approach ensures comprehensive care planning and promotes the integration of diverse professional perspectives for optimal patient outcomes. Optimal, best care, all mean the same thing. But this care coordination and communication is huge. Never really thought about it like that. So, what if the patient in room 201 was being discharged home? They were going home or they were going to a long term care facility. Okay. So, let's just take the patient is going home. So, in the chat, just no, let's come off mute. So, just share one thing that we should consider if this patient is going home. They're being discharged and they're going home. Share what you think.
Their support system.
Okay. So let's be more specific. If they have like a caregiver, if they have someone that's going to be taking them to their appointments, they have someone that's going to be coming, fixing their meals. It's like, so what is that support system? Because don't we need to know if they have that, especially if this patient is not going to be able to provide all the care that they need for themselves. Because home might not be the best place for them to go. Good. Anyone else?
Medication compliance.
Exactly. Comply understanding of why are you taking this medication? Why do you need to check this pulse before you swallow this pill? Ensuring that they understand what these medicines are for. Well, we have our little time charts and we're coming in, but what does twice a day, what is it going to look like for your client? Piece that out, have that conversation because, they may have a schedule where, I don't know, we're going to say that they may have to, I don't know, they may be walking dogs at 10 a.m. Then they have to walk them again at 7 o'clock, 7 p.m. So, but they're trying to keep up with the times that we actually came in the room and gave them their medication. So what does twice a day look like for them? Good. Someone else.
Is
Go
their
ahead.
environment safe at home?
Is the environment say yes? Because a lot of times, patients just walk out and they're back to that optimal level. And so lighting, stairs is not an issue. But what if that client, they're well enough to be discharged, but they're not back to that optimal level where they can walk up and down stairs. But then they have stairs, they have to walk upstairs to get to the bathroom or to the place that they're going to actually sleep. These things need to be addressed. Okay. So what about this patient being discharged to the long-term care facility or nursing home? Let me hear from you. What does that care coordination and communication look like? This patient is being discharged to the long-term care facility or nursing home.
There's like a complete handoff communication done between the nurse taking care of them and then the nurse they're going to be with.
Hand off. Yes. So we're handing off. So this person is going to a long-term care facility, then we are no longer going to be responsible for their care. We're handing them off to the next person or entity, whether or not it's home health, whether or not it is they're at the long-term care facility, they're going home, or long-term care facility to long-term care facility. Sometimes patients get transferred within the same setting. So that is information that we need to give and communicate to the next people or persons that is responsible for this patient's care. A handoff report to the nurse, if it's the home health nurse, long-term care facility nurse, ensures the next provider understands what this patient needs, what the medications are, what supplies, what equipment they need, and what follow-up care they need. We need to know if they have any upcoming appointments, if we're supposed to make upcoming appointments. If they need to return to get their stitches out, they need to return to do a repeat x-ray. So yes, a hands-off report to the nurse ensures the next provider understands how to provide the best care for this client. And providing that best care does not leave out anything. It considers their environment, their medications, pay status. If their medications, if their insurance is not paying for a medication that they need, we should have identified a payer source. Because sometimes these pharmaceuticals, they do have like coupons and things like that. Because if the person needs it, but then they can't afford it, is it just enough for us to know that this person needs this medicine? No, we have to seek out resources and see if there are any organizations, that there are different types of payer sources or paid resources out there that might can assist. Okay, here we go, you all. Patients being discharged. I'm going home. I need to really know and understand what you are talking about, nurse. So we need to make sure that we're providing clear, written discharge instructions so I can refer back to them, making sure that information is in my language. If we have to, they can, like the last time we discharged someone, they had like the system where you can go in and change up. Well, it was the same discharge instructions, but it was put in a format so that, people want a chart, you can flip to a chart, just like how I do the PowerPoints. I just change them up and add in pictures and images. But nevertheless, we want to provide clear written discharge instructions so this patient can go home safely, even in the event that they are, they can refer back to them. Not necessarily that they might have memory issues. They might. And they might, because it's new information. For the most part, it probably will be new information for them. The patient came in with a headache and they, getting discharged and they realize they have hypertension. So this is new information for them. And so they can refer back to those written instructions. You need to know these things. That handoff, we're using that S-bar. We have that structured way to communicate so that we don't forget anything. All right, here, I may need to change this slide right here too, because I think my picture's too busy, but I wanted you all to, let's look at this right here. Refer to the previous scenario. If handoff was completed and discharge instructions were completed effectively, what does that mean? That the patient understood. The patient understood, not that we understood as a healthcare provider. Remember, we're healthcare professionals, so our knowledge base is going to be a little bit different from our patients. Like, things that we're going to really readily understand. So we want to make sure that the patient understood. Okay, thinking about that. So we discharged the patient. We go back to this line. We provided clear written discharge instructions. We did our handoff report. Everybody understood. Even if we were going to facility, the staff understood, or the patient was going home, the patient understood. Everyone understood. This is my question to you. In the chat, I just need you to put an I or a D. My question to you is, would it increase or decrease the likelihood of hospital readmissions? If everyone understood, patients getting discharged, instructions were clear, written down, they can refer back to them. Everybody understood. What's the likelihood of this patient being readmitted? Would it increase or decrease the likelihood? You can just put an I or a D. What do you think? Give you a minute to think about that. So this is another scenario where we are taking what we understand about handoff report, collaboration, communication, and we're applying it to a scenario. Let's see here, what you got. So we are saying, oh, yes, I agree. More than likely, it is going to decrease the chances of that patient being readmitted because they understood what they need to do. We've talked to them. And also, if we've identified resources that they might need, we've answered their questions. We've even considered, their preferences. So if it's something, or intervention that they may not have liked, we've already changed it because we consider their preferences. Okay, so let's do this different. Let's mix it up. I want someone to just each part, I need 3 people to read for me. One person read a bullet. Let's pause. Next person read a bullet. Let me hear your voices. So someone read the first bullet for me.
Communication competence in nursing requires that communication be both effective and appropriate.
Would you like to expound on that? And it's okay if you don't, if you don't want to. What is it both effective and inappropriate? What does that mean?
That probably that everybody, like all the providers and physicians are on the same page and that the patient understands what's going on.
Okay. All right. All right. Who's our next person? Read our next bullet. Oh, that's our little timer.
Effectiveness is achieved when the goals of the communication are met.
Okay. And our last bullet.
Appropriateness is achieved if the communication is well adapted to the people and situations it involves.
Okay. And we go back to what I can't remember who just said that. Everybody's on the same page. We all understand what the goal is. We all understand all the steps to get to this goal. It's been communicated. That questions are answered. Even if questions arise, we know who to call and ask those questions to. And part of your discharge instructions, have you all done discharging yet? Discharge anybody from long term or even ER? And what do we tell them? Hey, even in the event you get home and there are questions about the information that we have, hey, call us back. Even though they have been discharged, we add that little piece in there. So effectiveness is achieved when the goals of the communications are met. Appropriateness is achieved if the communication is well adapted to the people and the situations involved. We consider all healthcare professionals, doctor, the dentist, all of these. We've considered what the patient wants. Well, I don't want to go have an appointment on a Wednesday. So we don't make appointments on Wednesdays. But the patient might have to travel to the next clinic or the town over because the doctor only sees patient in his town, his or her town on Wednesdays. But that's communicated. Great, great. All right. So we have these different styles of communication. So I will say that students have said on the HESI as well as delegation these different styles, that there'll be like scenarios and you'll have to pick which tone the scenario is. Like, is this an assertive? Is this being respectful and honest? Or is this person passing the buck and really not, fulfilling what the need is or resolving the issue, non-assertive? And then aggressive, is this person being rude and disrespectful? So they have shared that as well. So non-assertive, it is fear-based. Emotionally, it's really being dishonest and self-defeating because we're passing it on. We're not answering or seeking out a solution. You might not have the answer, but at least seek out the solution. We put the person in contact with who can provide the answer. Well, I really don't know. You just have to ask the next person. So that's, being dishonest. Even if you don't know, still, well, I don't know, but let me ask my supervisor. Or let's make sure we ask your healthcare provider when he or she comes back in. That would be a better way of addressing it. So, factors that affect communication. This situational thing right here, you are. A person's in pain. If they're like, for example, if they're in the hospital, even long-term care, if they are sharing rooms and the person next to them has a wound that has an odor, we might want to coordinate, communicate that, hey, this might be the time that patient, if they have therapy, that they go down to therapy. So they're not in that room when we're doing that dressing change. What is the facility policy on taking care of odors? Some maybe open the window. Some, they have different things in different facilities is what you can do. But the situation, the noise, making sure that we're answering those call lights because that's noise. That's not a natural thing that we should be hearing. What's another one? In the hospitals, we have the pumps are going off sometimes, the bells are ringing, just making sure that we are paying attention and answering those as best we can, because that noise, it impedes people's healing process. The person's sick, not feeling well, they're hearing all these things. that slows down their healing. So we want to think about the person's age. Who are we talking to? We have a infant, so we're talking to the parent. So, but what if the parent is a young adult? What if the person is an older adult? So we want to think about these things. Can the person read? If they said they can read, are they fluent, or do they need it on a certain level? Well, hey, yeah, yes, I can read, but it needs to be very, very simple. So we need to make sure that those written instructions or whatever information that we're giving them is in a format that they can understand it. Because otherwise, you're just giving me information. I can't do anything with it. I don't know what you're talking about. So just think of it like that. We do want to consider nonverbal and verbal. So as we're interacting with our clients, we need to be writing down when we're documenting. Include what that nonverbal, those things that you observe. Patient was the voice tone. It was high pitch. It was very low. How was their body? Person was sitting erect, or was the person, sitting, with arms crossed, or, folded over, body bent forward, or, include all of that, because it adds detail and gives us a clear picture of what's going on with the client. So we do want to make sure that we include nonverbal and verbal information, details. Okay. So, question to you. You can come off mute and tell me, share, what are some examples of non-verbal behaviors? Non-verbal. What are some examples?
Eye rolling.
Okay.
Shrugging shoulders, shrugging of the shoulders. So nonverbal.
Oh, shrugging the shoulders up and down. So you're asking a patient questions and they're non-verbal, but they're motioning their shoulders up and down, or moving their head from left to right or up and down. Because sometimes the patient is so whatever is going on with them, can't be verbal right then. But we ask them a question and they can answer the question, but they're not verbal. So we can write down, because I think it's universal. If you go from left to right, that means what? Is that yes or no? From left to right?
No.
No, exactly. So you can be as detailed and says, patient asked whatever the question was, motion head, up and down, or left and right, or shrug shoulders up and down. So yes, good. Okay, facial expressions. Oh, let's go back. Facial expressions, distractions, gestures, posture, body language. If they're fidgeting, or even if they're yawning, more than one time, several times. What's going on with that? Okay, active listening behaviors. I am listening to you. When we repeat what the client said in a slightly different way. And all of this is part of communication. You don't have to do this with every conversation, but you may pick one or two of these techniques out. I think we have 6 of them. So, but because sometimes people are saying things to us, and when we interpret them or receive it, it's not what the person intended. Like, wait a minute, now that's not what I meant by what I said. So clarifying and restating, asking those questions in response to the client's statement, to be sure that we understood what the client is actually stating to us. We can use reflecting, or we can paraphrase, express our own words of what we think the client is saying. And then this way, if information that we're receiving is interpreted incorrectly, that patient can quickly tell you, hey, nope, that's not what I was talking about. That's not what I meant. This one right here, remaining silent. So we were at a seminar, and asking everybody to introduce themselves, and how they have these little icebreakers. And I think what was the question was something about what brings you most joy. I think that's what it was. Because the icebreaker was a question that pretty much could get people to talking and everything. That was like the whole point of it. But one participant, was they told who they were, and then they got up and they were like, this person in their life brought them the most joy because of all these things, that they did, and, through the good, bad, and ugly. But now this person wasn't in that capacity due to an illness that was pretty much terminal. And so while the person went off script, so to speak, but we just remain silent and allow that person to exhale in that moment and just get it all out. And that is active listening. That is therapeutic. So sometimes when your patients are talking and they may state something, and we want to encourage them to continue on. We may have to do hand motions or make those sounds go on or that's active and that's therapeutic. Summarizing and validating, these are active listening skills that we can use too, just to ensure the information that they have sent to us, that we are actually receiving it as it was intended. There's no mix up. We talked about open-ended and closed-ended. There are sometimes when we have to, especially if the client answers yes to, for example, if you have pain, where's your pain at? What's the next? What else do we ask? Anything that helps your pain? Anything that makes your pain get worse? Have you taken anything for your pain? Have you done any non-pharmacologic interventions, such as the back? Have you rubbed the area? Have you placed heat on it? Asking those more focused questions will provide more definitive information. So just think about the information and the why you are asking or having this conversation with your patient. And then you can decide, well, hey, I need to ask a more open-ended question because I need more information. But think about it. If you're asking those closed-ended questions, you're pretty much going to get that yes or no, just that specific answer. But focus questions. When do we need to gain more information? Focus and open opens the door, but then like the example that I just gave about the pain, are you in pain? Have you ever been in pain? Then that focus question, when, how, what helped it, what made it worse? That's a more focus. So we do need to be aware of our body language when we're talking to our patients, even when we're doing dressing changes or procedures. Just try to make sure that face stays all nice and calm, and so because they pick up on our body language and our posture, and we don't want them, getting overexcited based on what they think our face is saying. Using our messages, that is positive. Positive. Establishing this eye contact. We don't want to be using glaring eyes, and someone said rolling their eyes at our patients. We don't want that. We do want to make that eye contact. We'll look away, and so that's okay. And we've established that therapeutic relationship. So we do know whether or not if that's offensive in some cultures, because some cultures, they don't want you to make eye contact. But because we have established that therapy relationships, our patients, they have told us, you know, you know, my space, you can come in and talk and whatever, but if you're not doing a procedure, I need my space. Don't do the sustained eye contact. Attentive listening, empathy, and developing trust will facilitate effective communication. It's like the little gas in the gas tank. It makes the car go. It makes that client that best care that we can provide for our clients, because we have understood what their preferences are. We've listened to them. The clients wants to, Wednesdays is just out. They don't want to do anything on a Wednesday because Wednesdays they day to day play whatever, spades, dominoes, or they paint. And so because we have listened, and part of listening, attentive listening, we've clarified information. We have provided information in written. If it was discharge, we provided written documentation, discharge instructions for them. The things that we're communicating, they're good. They're effective. They will take place. What's another word for effective? I'm trying to use some other words for effective. What's another word for effective? And you can come off mute and tell me. So what's another word for effective? So communication took place. The things we said, the person understood. They really did understand them.
Successful.
Successful. Good. Thank you. Uh-oh. Went back to the wrong slide here. Let me stop sharing. Go back to our PowerPoint. Where did it go? Uh-oh. I think I closed it out, you all. So when we say effective communication, really, what are we saying? What does that mean? The information that, we were given the clients, they understood it. They asked questions about it. Waiting on this PowerPoint to open back up, you all. Any questions so far? This collaboration, communication is huge. It's a big, big piece. Okay, is it over here? Okay. Using those iMessages, we talked about that. Okay, this is where we're at. We're gonna elaborate a little bit more on for some reason when I go to share, it's wanting me to share us. Okay, here we go. It was only given our little Zoom as the option. So assertive communication is honest. It involves expressing ideas and opinions openly while remaining respectful to others. You know, even if you have an idea or you think it should go this way, it's still a way to express it without being aggressive or even passive. Using I statements to express one's thoughts, feelings, or needs clearly and directly. You know, we talked about last time where your professional ethics may collide or bump heads with your personal ethics. And so if you work in a facility and you know, they have a task that we can lawfully complete because our nurse state practice act says, hey, we can do that, but then personally we might not want to. So that's a conversation that we would have with our nurse manager or whoever makes the decisions about the task that we're assigned. So we use those I statements to express one's thoughts and feelings and needs clearly. Another example is the patient, they may confide in you, say, hey, nurse, I just signed off on that because that doctor was in here, you know, he or she is in charge. So I just signed off on it. I really don't want that procedure. So this is where we have that conversation with that patient about talking back to their healthcare provider and just telling them how you feel about it. And so that client gets that best care that they want. This approach allows for honest expression without blaming or attacking others. It promotes effective interpersonal communication. Communication, collaboration. Wow. Okay. So then this slide just talk about negative communication. This one right here kind of we might get slipped up on this one, that's giving advice because we're the person that the patients readily see the nurses. So, and you know, you've established those therapeutic relationships. So they don't mean anything by it, but they will often say, well, nurse, what would you do? So we need to get it back to them. Patient, do you need more information so that you can make an informed decision? We want to give it back to them. We don't want to say, hey, I wouldn't do that if I was you. Or that doctor, his reputation, he's done this 100 times and there's only been 2 mix-ups the times that, you know, we don't want to be giving advice. Well, hey, do you need more information so that you can make an informed decision? And we add that piece because we're going to support whatever you decide you want to do because we want to support their autonomy. False reassurances. Oh, you're going to be okay. Nope. Don't. So if they have specific questions or if they have questions, we want to bring whomever back, the dietitian back, whoever it is, to answer, to give the, you know, the most knowledgeable answer that they have, but we don't give the false reassurance. Oh, you're going to be okay. You know, and a lot of times doctors and things, they'll go ahead and say, hey, we have 80% success rate. They'll go ahead and tell people. So, and they're supposed to, so that they don't give false reassurances. Okay. And so we will stop here. We're at the bottom of our first hour. We're going to stop and take, let's just do a 5-minute break. So we'll see you back at 9:06. We'll see you 9:06. Yeah, remember this video still plays, so just make sure that we're not seeing or hearing anything that we don't need to, because it's still recording. All right, so come on back on camera. And again, just remember those do's and don'ts of being in the classroom, you all. All right, let's get to moving here. Let me just do some questions. Let's see, let me make up some stuff here. Let's see, making sure that we so we talked about coordination, how important it was. But be specific. What does that care coordination do for someone's health care? Think about those different examples I gave. What does coordinating that care overall do for that person? What would you say?
Helps them attain achievable goals based on them.
Okay. If that client understands the written discharge instructions, more than likely they understand they've asked questions and they got answers. Is that client going to more than likely probably take care of themselves like they're supposed to, or pretty close, or not?
They would. They would
They
take
would.
care of it. They would.
Exactly. That improves that quality of care. Exactly. And then what does that do for that person? If they pretty much understand what those instructions are, what to do, the to-dos and the don'ts, and they pretty much do most of the do's, what's that's going to lead to?
Better health
Successful,
overall.
like
I heard better health overall, and then I heard someone else talk.
it would do like she said, better health, but more of a success rate for like healing or continue like to stay on a healthy journey than the back.
Okay, great. So what would it do for cost of healthcare?
We'll lessen it, less hospital stays
Got
and
it.
less.
Exactly. It's going to be reduction or decrease in healthcare costs. Because remember, they understand the questions that we already got their preferences, so they're more likely to go to that doctor appointment because it's not on that Wednesday when they have to play golf, things like that. So overall, their quality of healthcare is going to be better. It's going to be improved, and it should reduce the cost because they're getting their follow up like they need to. And then what did we say the Affordable Care Act? What did it shift toward? What was it looking at? It was one word that specifically, but what did the Affordable Care Act, what are their delivery of care? They're focused on what? Begins with a V, and we talked about it. Value. Gotta remember this, you all, value. They're putting things on value. Remember the number of hospitalizations, readmissions, how many falls, how many readmissions, how many medication errors. They're looking more at that value based, Okay, so this state said that they needed, a 62 patient ratio. Well, this state is providing that 62 patient ratio. So let's look and see how many falls they're having. Let's see how many UTIs that they have. Let's see how many readmissions. So they're valuing, that the healthcare and the things that the states or the people have said that they needed. Is the care more valuable? I don't know if that's a better word, but they're looking at the stats, so to speak. Is it showing that there's a decrease in rehospitalizations, a decrease in falls, or there's an increase? What's really going on here? So the Affordable Care Act, it identified care coordination as is fundamental. That care coordination in helping healthcare industry move away from that fee for service. Because remember, initially it was a fee for service. And then it focuses more on value, VALUE, based care delivery. And the whole thing is still wants that best quality of care for those clients. And then also it wants to decrease those costs. I don't know if y'all looked at a bill, but they see that thing like, what the world? What did they do to me to have for the price to be this amount? But those healthcare costs are gigantic. They're huge. They're astronomical. Whatever word you want to use, they're a lot. So we can do things to improve the quality of care while reducing healthcare costs. That's what we need to do. So we invite that spirit of inquiry. That's where, can we do this differently or better with better outcomes, but using less resources and things like that. So we encourage that. So we have a patient that's being discharged. Let's go back to that patient we had. They were in room 201 and they are being discharged. What do we need to ensure that this is a successful discharge or transfer to another facility? What things that needs to happen? Somebody said it right off. I forget who was at that said it early on.
Proper handoff communication.
Yep. And let's take it a step further. You're spot on. What does handoff include? What are we saying when we're handing off? Just give me some examples.
Their medications, the way that they move, whether it's with an assistive device, their meal, like their diets, who their like emergency contact is.
Got it. Good. Patient needs, medications, medical devices, oxygen use, whether or not it's they have follow-up appointments, they have wound care, all of those things, handoff report. And then what's that other thing that we're going to give them in writing? Making sure that they're clear. Those what?
Teaching.
Discharge instructions. Make sure they're clear and that it for the most part they should be written discharge instructions. They can refer back to them. Because think about how many times we refer back to whatever. Even if they take a picture of them, they still have that in writing. So that continuity of care, you all, that care coordination, when we're coordinating all this stuff, that patient care just continues. There's no stops. It's seamless. It's beautiful to see when you can step back and think about the bigger picture for this patient. Yes, we have 6 patients that we're responsible for, but we can step back and kind of piece through, okay, think it through. Okay, I need to have this done here. So we have a conversation with this person, pick up the phone, that it provides that continuity of care. And it's that seamless transition of patient care, even if we're going home for the day, if we're transferring this patient to a different facility, if the person is going from like hospital to long-term for rehab, even if this patient is being discharged from our facility and they're needing a level up of care, different levels of care, still that transition is seamless. That continuity, that patient care does not stop because we're in the handoff report. We're given the information that is important to take care of this patient. That continuity of care, it also when things are communicated effectively, even if things happen that are not so pleasing, it lessens the chances of backlash because we've been proactive about things. Things sometimes still happen even though we've been proactive, and it lessens that chance of that backlash or of us not identifying what could have or what could possibly go wrong with this client because we're thinking it through. So we can provide that continuity of care. All right. So what else did we talk about? Let's see. What else here? We started talking about communication. Let's see here. Give you some examples here. I'm trying to think of some sentences. So assertive communication. So someone tell me what do you understand assertive communication to be? And I'll think of some examples and you tell me when it's assertive or aggressive. So right now, give me a definition of what you think assertive communication is.
Maybe like straightforward.
Straightforward. Is it
A
straightforward
good
and go ahead.
or a good eye contact.
Okay. Making eye contact, straightforward, but not rude. Okay.
And
So
clear.
What'd you say?
And clear. Your voice is clear. Very
Clear.
clear. Mhm.
Okay. So let me think of some states here. This is Nurse Nancy talking. Nurse Nancy says, "Hey, I've been a nurse here for 20 years, and you newbies just coming on board. I've had the most experience, so it's gonna be you should just listen to everything I say. So the nurse Nancy's being honest. She's been there the longest. Let's see, what else is Nurse Nancy saying? Is that assertive or is that something else?
It's aggressive.
It's
It
kind of
sounds
aggressive.
aggressive.
Yeah, that's kind of aggressive. I mean, she stated a factual thing that she's been there the longest, but still, everything shouldn't just go the way that Nurse Nancy says. Okay. Well, what if Nurse Nancy says, hey, I've been here for a while and we could, I think we should talk more about whatever it is that we're talking about. Are you open to that? This is Nurse Nancy and you having this conversation. So Nurse Nancy says, hey, I've been here for a while. I hear, what you're saying, but are you open to discussing this further? Is that aggressive, passive, or assertive? Do I need to say it again? Because I did kind of
Assertive.
Okay. All right. So there was a whole different tone, right? Nurse Nancy, she's been there for however many years, but it was honest. It wasn't aggressive. It wasn't being rude or disrespectful or anything. So assertive communication, remember, is respectful. It's direct. We're not bending the truth, changing up the truth. We're being direct, being honest, and it at the end of the day, it ensures the patient's safety, and also it promotes that collaboration, whether or not it's nurse to nurse or nurse to the others that are on the healthcare team. All right. Let me see. Let me try to think of another example here. I believe that the patient in room 201, and I always pick on patient in 201. I don't know who's in that room, but I'm sorry, that's just a number that comes to mind. This is Nurse Nancy talking. I believe the patient in room 201 might need to be checked on a little bit more often than every 2 hours. What tone is that?
Passive.
Okay, so is that statement Nurse Nancy's own thoughts? Did she communicate clearly what she thought that should happen with that patient in room 201? Because she says more often than every 2 hours. Now, the patient 201 doesn't belong to Nancy, but you all just having a conversation about your patient in room 201. And Nurse Nancy says, I believe.
That would be assertive because it started with I. She's saying I believe. So she's saying like directly saying, you know, she's being direct as to what she's seeing or what she's saying.
Remember, we said assertive starts off using that I statements too. She's being direct. She's not being aggressive. Yes, don't forget that I statements. Great, great, great. Okay. Yeah, y'all got it. Y'all got it. Okay. Let's see. Assertive, true or false? Assertive is being rude to others.
False.
That's false.
Assertive is not being rude to others.
That's true. It's not being rude. You're not being when you're assertive, you're not rude.
Got it. So
Direct.
Got it. So you went back to what you knew assertive was. That was a test taking tip. So no matter how you all understand what assertive is. So I just asked you two different scenarios and you all answered correctly to both. But you got to go back to what you know that assertive is in order to answer that question correctly. Because I just changed it up. I put a not or but or something. I don't even remember what I really said, but you all responded correctly. So that was a test taking scenario. You all make sure that you're reading the question correctly. Sometimes we'll read, I think our brain processes stuff so fast and our eyes are still trying to catch up with each other. So read it again and make sure that you're going to answer what they are actually asking you to answer. Yep, you all did good on that one. You all didn't get tripped up. Good. Great. Let's see what else. Assertive. We gave you some Some examples, you all pulled that out. We talked about the definition of it. We haven't talked about conflict resolution yet. We're going to get to that here in a moment. I may have to pop down to the end of my slides. But anywho, let's go back to the PowerPoint. So I think we've got it. We want to make sure we're taking the time to go over this because, like I said, more than likely it's going to be next June. You're going to have to think it through and all of that. So let's talk about S bar, you all. Before I share my screen, S bar is the next thing on my screen. What is S bar? What do those letters stand for? What is that whole process?
Situation, background, assessment, and recommendation.
Okay. So what's happening under the S, the situation? What is that all about?
Basically, what's going on?
What's going on? Okay. And give me some examples. Take it a step further. Situation. So what's going on? Someone give me an example of a situation.
Patient comes to the ER with maybe chest pains or something. That's the situation.
Okay. Good. Medication error. We're calling because the patient received the wrong medicine. We're calling because the patient's complaining of pain now. Patient didn't have any urine output for the last 2 hours. We're calling because, yes, so it's whatever is going on. Good. So what other information do we need to give the healthcare provider when we are calling about a situation?
The patient information, but also your information and where you're calling from.
Got it. Good. All right. So what's that next letter? Let's talk it through before I show that slide. We're gonna see, we're gonna check ourselves once we get to the slide. What's the B for? She just told us. Okay, gives us some examples. What does that mean?
The patient health history.
The health history, any current conditions, their current vital signs, stuff like that.
Okay, their current status. So with their vital signs, we want to give the ones that's most recent. And, and if we have some for comparison, we can give those too, but we do want to give that current status of that client. Hey, right now they're oriented time 0. 2 hours ago, they was oriented times 3. They were oriented to the person, place, and time, whatever it was. But give that background. They're confused. This is not of new onset, or this is of new onset. They have diagnosis of, Alzheimer's, blood hypertension, whatever it is. Give that background. They are a full code. Do not resuscitate as much as background information as you can. So what is that assessment piece? We did the S, the B, the A, the assessment. What's going on there?
What you think is going on or what's happening?
Okay.
You actually like looking over the patient, trying to see what's actually going on. You're gonna like do the vitals and check their skin. Like just look over the patient to assess the actual problem, or if it's a focus assessment, say if their knee hurts, that's what you're gonna pay more attention to, just to kind of like get the pain rating, things like that.
Okay.
What you think is happening
Got it.
based on the patient's condition?
Okay. Okay. We're calling because the blood sugar is low. We have a history of diabetes. In our assessment, the things of what we think is, is going on. This patient didn't eat breakfast. They didn't eat their supper. It looks like their intake has been low for the last couple of days. And they're not going to have their medicine. You want to give all of that, what else is going on with this client. Then recommendation, what's going on with that?
Anything that you see going on that you recommend, like what type of treatment you recommend?
Okay. Even if it's like, hey, we need to transfer this patient up to ICU. This person needs to be discharged to the ER. What do you think? We've noticed that this patient, this patient's complaining of pain. Well, the trend is this patient starts requesting more pain medication or complaining of pain an hour before it's time to get their medicine. So this patient might need something for breakthrough pain or whatever. May need an additional medication or a dose change. So it didn't mean that they'll, the healthcare providers will side with whatever, but we're there. We're spending the most time. And so you're the eyes and ears, that lifeline between them. So they want to know, you're a valuable part of that healthcare team. So they do want to know what you think. Got it. So what we talked about, what does a respiratory therapist do?
Maintain the airway.
So all things airway, anything breathing, lungs, all of that good stuff. What about a speech pathologist, speech therapist? What do they see about?
Maybe help somebody that's like had a stroke who's having a hard time like speaking.
And they do
Okay.
swallow studies too, right?
They do swallow, I thought.
All things
Okay.
speech and swallow, teeth, tongues, exactly, throat, exactly. So the UAP come and say, hey, this patient's drooling now. They're letting food fall out of their mouth. They're coughing while drinking, their milk or whatever. So yes, we of course are going to report the findings, but more than likely we're going to bring that speech person on board to see what's going on, the dietitian and the speech person, because they do those swallowing tests, make sure that food and those liquids are going down correctly. And then also with the liquids, I don't know if you all have seen like those thickened liquids. If they deem that the patient can swallow safely, but they need those liquids, honey consistency. I think I've seen honey, nectar is one other consistency, but they're not thin liquids like how we would just normally drink a Coke or some water. They call those thin liquids. They're thickened. So yeah, all things speech, teeth, tongues, voice, sound, things like that, and swallowing. Okay, so we did pretty good on our S bar. We got them all. And this is just showing when we're doing handoff shift report. We don't give as much detail. For the most part, these shift reports, I don't know if you all have seen those cardexes, and you may have a sample cardex too when you're in clinical where you give that report to the next person. It's that minimum data. And those electronic ones, what they do is the information that the nurses have been inputting all shift, they have it pre-packaged and preset. So when at the end of the shift or near the end of the shift, they print. And it pretty much has all this information already there for you. Otherwise, you know, back in the day, we used to record. We used to do handoff or shift reports several different ways, but nevertheless, at a minimum, we gave this information. We have it written down. Even though they have that Cardex, you still want to make your little notes and things. And so, but we're giving this patient's care over to the next person. So, what is it that they need to be able to provide that best care for them so they can see what the baseline is for that client? And then they can determine whether or not this patient is going through some changes, that they're improving or if they're getting worse. And this is just saying, hey, we're communicating, like we said earlier, the patient is the infant. But no, we're talking to the parent. Parent could be, an adolescent, adult, so we want to ensure that everything is being communicated so that people can understand it, no matter what the age is. So charting, you want to make sure that what we're writing is factual, timely, thorough, taking the time to make sure we put all that nonverbal, verbal information that we're getting. We want to take the time to write all of it down. Don't assume. Be as specific as you can when you're documenting. Round it. If it's a measurement, get those measurements. If there's a shape, like common shapes, like circles, squares, and things like that, you can use those as a baseline or for reference, but be as concise to the point. Coughing continuously or cough every now and then, productive. What did it look like? Was the phlegm, was it, yellow, clear? Be specific as possible. Okay, and then take the time to do that now, because I know at the end of the shift, he's like, oh, I took care of the patient. That last note, take the time to go back and write your last note. Make sure everything is documented. We talked about aggressive already, assertive, and passive. Aggressive really, it violates the rights of others. It's like an attack on a person. It's anger based. The body language is not pleasing, it's not inviting. Like I said, it's a difference in making eye contact and when someone has glaring or rolling their eyes as someone stated earlier. That's different. That's showing us being aggressive. So conflict. Let's talk about this now. Conflict, it's a natural part of life. In the conflict, that mean that you're boxing it out with people. It just you may have a different viewpoint or understanding of something. And so we do need to ensure that, our attitudes and behaviors, and we're not throwing things and all of that is professional and being responsive and being safe to ourselves and the patients. We do want to be aware of our initial reactions. Sometimes you may have to step back and take a deep breath, count to 10 or whatever, but we do want to take time to think critically before reacting. We want to treat conflict as an opportunity to voice, like, this is a time for this patient to voice, the nurse to voice their side of the story. We do want to make sure that we're listening. And then remember those techniques you were saying earlier, paraphrasing, that we're clarifying things, because that will lessen the chance of some conflict happening. But sometimes conflict is just going to happen. But still, nevertheless, make sure that we're listening with an attentive ear. And then we do want to be respectful of the other. Okay. Now, a lot of times if the conflict cannot be resolved, it will. Now, this is another task that you can have. I haven't seen it where facilities have that's the only task that the nurse have, but you can also work on the ethics committee. So if the conflict can't be resolved, then they will turn over whatever is going on to the ethics committee. And then you as that nurse, that is usually a team of you all, will hear and review whatever for a solution, hear the information for a solution. You will gather information to make sure that you're not leaving out any information, because you make sure that you're looking at things from an objective view. Okay. All right. So improved team member satisfaction is an advantage of interprofessional collaboration. What does that mean? Improved team member satisfaction. What does that have to do with interprofessional collaboration? What do we think? Because we're collaborating with those on the team. The good, the bad, and the ugly. We're being proactive. We're already talking about what's going on, what could potentially happening. Things that the chances of something happening, catching us off guard, is going to lessen. And as a result of that, you're going to be more satisfied. Like, oh, I pretty much like working here. Things happen. We pull it together. We talked it through. We push through, and we provide the best care for this client. We're keeping ourselves safe, and we're keeping the patient safe. So as a result of that, you will have that increase in satisfaction of being part of that team. Enhanced communication among team members is an advantage of interprofessional collaboration. If you have that enhanced communication is effective, that is a huge thing. I don't know if you've ever been in a place where communication was not effective. That's that's not a good thing, and you don't want to be there. So yeah, so if you all are having to step away to use the restroom or anything, just let me know. Put it in the chat. Don't send it out so everyone can see it. All right. All right. So the next point was, and see, this one I should have bulleted out a little bit more. It says increase patient satisfaction with discharge transitions is also an advantage of that interprofessional collaboration. So this is a task too that you might have. What you do is you either give the survey or you go around and ask in person, how was your stay? How were your nurses? Were they rude? And these are questions that they ask. And in the event that the team has been collaborating, discussing all the things that this patient needs to get their best care, it lessens the chances for things happening. If things did happen, the team was responsive with a solution. Guess what? When they send those surveys out to those patients will say, hey, even though whatever happened, I was still satisfied because I still think that they had my best interest at heart. And also they were responsive to whatever was going on. And so what you'll see is increased patient satisfaction. The team members will be, they'll be satisfied. They'll be everybody. There are some places you all, and you probably have seen them, or as you rotated, they said, hey, the turnover here is low. So that means those team members, they are satisfied. It is kind of hard to get into those places because they communicate effectively. The team, it's not because things don't go on in that place. It's just because that team has decided we have to work together. And they've figured out that collaboration piece and that effective communication piece. So their turnover is low. All right, so let's look at this. It says assertive. Uses the statements of facts. We said that, no judgment. We said being honest. So the nurse says, or the person says, turn and reposition at least every 2 hours. That's a statement of facts. Complete the dressing change every shift. These are things that should be happening. So those are some other examples of assertive. It stands up for the patient's rights or the nurse's rights without violating the rights of others. Okay. Ethics committee, I kind of mentioned this already, are appropriate resource when other conflict resolution attempts have been unsuccessful. So once you all are getting ready to be finished here, within 6-7 more weeks, be getting ready to either apply for your temporary license or you're taking your NCLEXs here before the year is over. And you pretty much are kind of narrowing it down to those settings that you want to work in. So once you start doing those interviews, they get you through those main questions and they say, do you have any questions? Ask, do they have an ethics committee? More than likely they do. See if there's an opportunity for you to work on it. But just know that what you're going to be dealing with is where that conflict comes in and then they can't resolve it. So you'll be part of that person helping to resolve whatever those conflicts is within that facility. You could be that public relation person. Those are some committees. They don't really advertise that stuff, but those are some questions and things that if that's what you're interested in. Public relations, the ethics committee, but the ethics committee is for conflict when it cannot be resolved. And there's another committee that a lot of facilities have too. It'll come to me here in a minute. Again, we're talking about this assertive, you all. This is huge. Taking that positive stand, being confident in your statement, speaking openly, not to violate privacy or the rights of others. Our posture is straight. We don't have those folded arms. We're making that eye contact. So, and we just said, using those I statements, assertive communication often involves I statements. It comes off as less offensive. This approach allows for honest expression because it's really, how you feel without blaming others. This is what I am thinking of. And then it promotes that effective interpersonal communication. Going back to that slide, you all, I know that slide was kind of busy. Improve patient satisfaction, enhance communication, and all of that leads to improved satisfaction on that person on the team. It's like, hey, y'all, I can come back another day because, things have happened today, but we've got in there, we worked it out, we thought it through, and so forth and so forth. Okay? Assertive communication. This is another way of saying it. Involves expressing ideas and opinions openly while remaining respectful to others. Propose a discussion, like those examples that I gave. Being open to a discussion. So you propose a discussion, so somebody might propose it to you. Well, hey, let's talk more about this. So be open to discussing. It doesn't mean that they're going to change your mind about whatever it is, but that we're open to at least listening to new ideas or whatever it is that they have to say. Okay. And these are just some more examples that we just said. Measure, and this is us talking. We're saying, hey, this person's weight needs to be measured monthly. Their blood pressure needs to be taken every hour. Vital signs should be attained daily. These are just some things, some instructions and information that we're sharing. Okay. What should the nurse do? I think I mixed, let me see, make sure this is right. Let me read through this, y'all. So we have an antihypertensive is prescribed after checking The blood pressure. The blood pressure is abnormal, high or low. What should the nurse do? I think I put the wrong title on this. So I was mixing, trying to piece it out. So we're gonna answer the question, you all. What should we do if after checking the blood pressure, this person's on an antihypertensive? We got an order for this medication, but we check the blood pressure and it's either abnormally high or low. What do we do with that medicine? Or what are our next steps? Let me hear from you.
Don't give it, or contact the provider and let them know.
Got it. And wait for the next instructions. Got it. What about if we receive critical labs? The phone rings or on our communication board, facilities have a different way. It comes across patient in room 201, they have a high white count. What do we do with that critical lab, that information that we get, whether or not it's an x-ray or a lab report? What do we do?
Notify the provider.
Got it. Okay. So another example here, the patient has a discussion with the dietitian and has changed their decision about a nutrition intervention. Whatever the patient and the dietitian, they sat down and they came up with the next steps, the intervention. Patient says, they're gonna wait till you get there. I'm telling you, I've changed my mind, nurse. What's the nurse next steps?
Maybe ask them why so that then you could tell the dietitian.
Okay. So we're gonna notify the dietitian that they're changed with whatever added information that they have.
Yeah.
So, but we're not gonna say, hey, you're gonna eat this food or whatever the nutritional intervention. You're gonna drink this health shake. You shouldn't have told them. You shouldn't have changed your mind. No, we will not say that. We will inform the dietitian of what their change of preference is, and we can add that added information in. They remember, that the last time they ate, I don't know, blueberries, it made them break out, the stomach hurt, whatever it is. Okay, so here it is. Suspicion to that the family member is taking the patient's medication. We have a suspicion. So we're talking about communicating, assertive, and being honest. What do we do? We're going to confront that family member.
No, we're gonna report it. We mandated reporters.
Got it. Got it. Gonna report it. Even if we, like I said, it's a suspicion. We don't know, but we're mandated reporters. Got it. All right. We talked about assertive. This is assertive versus aggressive. We said this already involves expressing ideas and opinions openly while remaining respectful of others. Aggressive is like the opposite. It involves expressing ideas and opinions while violating the privacy and being disrespectful and rude. Got it. So remember, more than likely, they're going to give you some statements. You have to be able to pick out, is this assertive or this is aggressive or so forth. All right, so this chain of command. So what is it? What is your understanding that chain of command is, you all? Come off mute and tell me. Chain of command.
When you have a situation at work, or for instance, wherever you work, you know the right person to go to. You don't first go to your unit manager before you go to your RN, which is your supervisor.
Okay.
So you know where to start.
Okay. So we got this steps or levels of who we communicate with, and then the next person and the next person. Got it. Are there any circumstances that I agree with exactly what you said? But are there any circumstances from which we, the nurse, would deviate from that chain of command?
If someone in that chain of command was the problem, then we would maybe higher up.
Okay. Or lateral. Okay. Is there another circumstance where we might deviate from the chain of command?
Patient safety.
Okay. That patient is needing an immediate response. For example, if we go in the patient's room, patient has altered mental status, we did our assessment and everything, and we have this information. And so we need to quickly, because we need an immediate action for this patient, we're going to call that healthcare provider. with our assessment findings. We might bypass our RN supervisor, our next RN, you know how, in different facilities they have all these different people. We'll bypass all of that because that client needs an immediate response. Someone said emergency. How did you say that? Who was that that just said that? When I
Patient
asked that,
safety.
patient safety. To keep that patient safe, alive, and breathing as best we can, that patient needs an immediate response. So we might not wait on notifying that RN is in charge or the next person. So, but what if the healthcare provider we've notified, tried to contact them and they don't respond to us? What do we do then? What do we do then? Is it okay to just document, okay, we tried to contact them and we can't get him or her?
Go to like your RN or your supervisor to see if they have a way of getting a hold of the provider.
Exactly. It's not enough that we just stop there. We can't just stop there. More than likely, there is the nurse supervisor or the DON or ADON, they have different name titles or whatever. They would know what the next steps are. Usually they have a lateral person to contact. If that person, they have a procedure in place so they can be contacted. But every now and then, it depends on, I guess, where people are located at, maybe connectivity or something. And we can't contact them, even if it's electronic email or what we call it, mox mail. Something happens sometimes. But this patient needs an immediate response. It's not good enough for the nurse to just say, hey, well, I've done my part. I've tried to contact that healthcare provider. They just not contacting me back. No, we need to let that supervisor know because it has to be someone else that we can contact. Okay. So organizations, you all, they want and need organizational growth and learning. So we want to be sure we kind of start talking about that conflict early on here. So in the event that there's conflict and you on that, it can't be resolved, you work on the ethics committee. Sometimes facilities processes need to be changed. Now, we're not talking about us doing anything that's not on our to-do list on that Nurse State Practice Act, but things sometimes might need to be changed up. Because remember, facilities, for the most part, most of them are for-profit businesses. Even if they're non-for-profit, they still want to be open and provide whatever services they provide to their patients. So they want that growth. If it's something that they need to change up, they want to know about it. So don't be afraid to notify your supervisor, whomever, or to work on that team to find a solution for that facility, because facilities want that organizational growth. And that's how they stay open. That's how they're providing these services and things for the people that they serve. So going back to conflict right here, when conflict within a team or between the team and the patient or the patient's family cannot be resolved, that's when we go to the ethics committee. Talked about that. The ethics committee will gather more information. They will make sure that the information that has been collected is there's no gaps in that information. So let me come up with something. A conflict. The patient in room 201, their family member states that their mom or dad had visitors and their favorite shirt was gone. So they were sure that it was someone that visited today or yesterday. So, sure enough, whatever shirt that the family member describes is not in the room. It's not there. So we got that piece of information. Check laundry. Check, all of laundry parts, the dirty laundry, the clean laundry, the laundry that's getting ready to go out, getting ready to be washed and all that stuff. Can't find it there. So we would need to gather, what else? What other piece of information would we need to gather? They're saying that a visitor took their family member's shirt. What else? What other information you think we can gather to validate whether or not someone was actually visited this person or not? I'm trying not to say. What else we need to gather? The visitor's log. For the most part, whatever facility you go in, they have some way of documenting who's coming in and out. So whether or not it's a video, whether or not it's collecting staff statements saying, hey, did you see anybody visit this patient? Can you describe, was it a man, woman, what time of day it was? They can pull the visitors log. People are staying in. They have written logs. So that log will also help validate, well, hey, we have one person visiting your family member, and it was you on that morning. No one else wrote in. We rolled the camera back from the time frame that you said that you put the shirt in the room, and no one else has been in that room except staff. So time log. So this is that ethics committee now. You have to piece out, look at everything. Think about how else can you gain information to validate what they're saying the conflict is. And I said a shirt, but it could be anything, a shirt, a pair of shoes, a person's, a lot of times in long-term care facilities, people will bring some of their belongings like picture frames and some of their furniture. And so that's why you want to take the time to document and follow that facility's policy. They say that all belongings need to be taken to the social service person and logged in. We want all of that because people may forget that they didn't really bring it to your facility, and it was really at home, or I don't know. It can just get all mixed up sometimes. But nevertheless, conflict is part of it. But we have to resolve it. We have to think it through, like how can we gain information to sift through all of this stuff to provide an answer. It can get kind of hairy, but nevertheless, we can figure it out. But we have to just make sure we have all the information. So here it is. It's us and the PT, the dietitian, it's all of these people. We're on this team together. We're working together to meet that common objective, which is to provide that best care to your clients, you all. We have to coordinate that care because we've already said it's recognized as a standard. Care coordination organizes care and information around the patient needs and their preferences. So the interdisciplinary healthcare team is a group of professionals. We're all working together to contribute to the care that this client needs. That's what we're there for those patients. So we have a lot of theories. I think Henderson, and there's one more that comes up. But Virginia Henderson, her focus was on illness and wellness. Look, the person's sick, and then they're well. So the unique function that we as a nurse, what part do we play in assisting this patient getting back to the well side? What primary, or keeping this client well, what primary interventions, what secondary interventions, what tertiary interventions are we going to implement? So Virginia Henderson, she's most noted for her interest was in illness, someone being sick and them getting well. So illness and wellness. Okay. All right. So effective collaboration involves sharing observations and inviting input from other disciplines to optimize client outcomes. And this is the example that I always give you all. So therapy comes up to you and say, hey, the patient in room 201, they just won't. They've been refused in the last couple of sessions. And so just letting you know, we may have to drop them. And so, well, what do you mean they've been refusing? Well, I come down every day, Monday. They get 3 sessions, Monday, Wednesdays, and Fridays. And, I come down 11 o'clock sharp. I'm on time. Patient, if they go to the therapy room, they don't stay but a few minutes. They want to come back. But most of the time, they refuse to leave out of the room. Talking to that nurse and recognizing this patient preferences, their routines at 11 o'clock, I don't know, their favorite show comes on. And so what it does is that client, they're more interested in their show. They want to get well, but they're like, not this time. I got to see this show. And could be a real scenario, you all, but because we are collaborating, the physical therapist is sharing, verbalizing, communicating, hey, this patient is refusing their sessions. We're going to have to drop them because after so long, they do, according to whatever their regulations are, they offer it for so long, and because we're collaborating and talking. And when they said 11 o'clock, Miss Nancy in room 1, she likes, her family comes every day at 11. Her son visits every day at 11. No, can you choose another time for her? And so that will optimize that client's outcomes, hopefully for the better, because that way, after us talking and realizing that's the wrong time of day for her, even if you come at 11:15, the son or daughter is gone then, or the show is off, or whatever, what have you, Miss Nancy she'll comply. And then what's going to happen? That client's going to get back to their, more than likely, their optimal level. It's going to decrease readmissions and all of that. This client is going to optimize their client outcomes. Did I go too far off? Are you all following the scenarios that I'm giving? I'm trying to make it lifelike for you because, like I said, that next gen is going to bring it. It's going to bring some scenarios. The patient's going to have all these different chronic conditions and all of this stuff, but they want to talk about handoff report. So I want to give you those different scenarios so that you can think through. And but nevertheless, we want the clients. Okay, yeah, that's fine. If you lose connection, you all just make sure that you just log them back in or send some type of communication. It happens. I don't know. I know, like we had a how's the weather in your area? It was like we had a heat advisory in our area today. It was so hot. I think the heat indexes were like 115. And so they were advising people to stay in. And so those type temperatures, it can, as well as those storms, it can affect connectivity as well, any extreme. So going back to my little scenario, are you all following it? If it's not making any sense, I can make up something else and talk you through it. Okay, not hearing none, but for the bigger picture, we want to optimize this client outcomes. We want them to get back to their best, their optimal level, or as close as they can, prior to them coming to see us. Okay, so we're almost at our next break. We're gonna go ahead and start looking at some of these. Well, who's on this healthcare team? Got the nurse. We have all the different types of nurses, and then within these nurses, we don't have it here. The nurse case manager, nurse practitioner. We have the RN, LPN. We within that, you can have certifications within that. They're ranged from all different types of categories. Then we have the physicians. What do surgeons do, you all?
The surgeries.
And then what else?
They can determine like the pain medication that
Exactly. Because remember they did the surgery, they tell you, like, the clients, they give us orders for pain medication, for therapy. Like they'll say, this client needs to be, we need this patient to go ahead and start seeing physical therapy. Taking 2 steps, walking in the hallway, they'll give a distance and all of that. But they're the ones that's going to be prescribing that pain medication. They just did surgery on a body part. The family healthcare provider, those are those main persons that the patients will be seeing all the time, and they will point if the patient needs specialty care. They'll point them in the direction of who their next person is that they actually need to see.
They also write the orders.
I'll say that again, Ms. Carter, because I kind of bundled over you. I'm sorry.
Okay, I was just gonna say they also write the discharge orders, like what the patient needs to complete before they're allowed to leave.
Got it. Sure do. Sure do. All right. So we're gonna pick back up here and talk about all of those key players. Key players. They're right there with us. So let's go ahead and take another 5-minute break. We're gonna push our other minutes toward the end, you all. So let's see, return back at 10:07. 10:07.
And then why you still in the camera?
Oh, shucks.
All right, let's go ahead and finish on up. Remember, we're saving our other minutes toward the end, so we only have a few more minutes to finish it on out here. All right, so what was I thinking of? And we're getting ready. We're talking about the team persons on the healthcare team. So let me go back to effective collaboration. We talked about effective communication. Well, let's talk about effective collaboration. Let's go back to that care coordination. So which of these more than likely will lead to effective collaboration, which also will lead to effective care coordination? Would just deferring everything to the doctor. When I say everything, like decisions, like the patient, we see that this patient is being incontinent, you know, we might want to offer assisted bedpan or the urinal more often. Is that something do we want to defer all decision making to the healthcare provider? Would that equal effective collaboration, which leads to effective care coordination? Waiting until the doctor tells us what to do for all of our decisions.
No.
Okay. So that word all, you all, makes that wrong. So things that we need, specific orders for, of course, we're not writing prescriptions and things like that. Of course, those things, but that word all. So if we're talking about this patient says, hey, I haven't been really liking those food choices. Do we have to wait to the doctor to tell us to go notify the dietitian to come back in to look at the menu options? No. So we're not going. So test taking tip. Be careful with those words like that, saying all. So my question was effective collaboration with everybody on the healthcare team, which, if it's effective, is going to lead to effective care coordination, which is going to lead to patient better outcomes. It's going to like domino effect. It's going to be all for the good. It's going to be positive. All right. So would trying to avoid conflict, does that equal effective collaboration, conflict, or disagreements?
No.
As we just said, conflict is going to be part of it. And no matter if the conflict is valid or not, it's going to be some conflict. That's just part of it. And so avoiding it, no, if there's a conflict, remember we need to address it so we can see what the issue is and have a solution. So avoiding it, no, that does not lead to effective collaboration. All right, so let's see one more. Then we're gonna move on with the other people on the healthcare team. What about if the team members, physical therapy, like the example that I just gave, the scenario, physical therapist says, hey, we're getting ready to drop the patient room 201. They're refusing all their sessions. We come every day at 11, I'll be on time. They're refusing all their sessions. And because the nurse have actively listened, received the information, and interpreted correctly, and that nurse says, well, hey, you say you come at what time now? 11. Well, Miss Nancy likes to watch, I don't know, whatever comes on at 11, or that's when the daughter visits or the grandson visits or so forth, because we have collaborated and talked about that patient's relevant information, because it's relevant that this patient has a standing appointment at 11 o'clock on Wednesday, even if it is with the TV show, because that nurse had actively listened and then contributed. And when the nurse says, hey, can you come at a different time? If you have to see this patient on Wednesday, can you flip the time with another patient? Can you exchange the time out? Because that nurse had actively listened, the therapist has actively listened, they gave relevant information, and they came up with the next steps. Is that effective collaboration?
Yes.
Okay. Yeah, that was a long drawn out scenario, but yes, I want you, when we say effective collaboration, I'm trying to give you some substance of what that could look like. So those are conversations. And yes, that is active listening, because the nurse and the physical therapist, they were listening to each other. They were going back and forth, saying this and that, stating the facts, being assertive, not aggressive. But you're gonna see my patient. You can't not see my patient. They can refuse, but okay, let's talk more about tell me what's really going on. They're refusing. What days are they refusing? So yes. So effective collaboration. It is an interdisciplinary team approach. It involves everyone that's involved in that patient's care to listen and to share that relevant patient information. We got to, because remember, we're there to provide that best care for our clients. Okay, so what does a pharmacist do?
Provides the medications.
Okay. Now they even do like some counseling if you want to. Most of the time they hit the little X for you. They say no, you don't. When you go get a prescription, but because someone can come talk to you, but they look at those prescriptions and they fulfill them. They dispense those medications. What about a social worker? What is a social worker?
Provide resources.
Mm-hmm. But it's everything from A to Z, all different types of research. They identify them. They try to connect people with those resources. What about that case manager? What does that case manager do?
They can provide resources, but they also have a little bit more, like if you have insurance, if you have like home health, some of your case managers are able to contact those agencies.
That is correct. They're a little bit more specific and they go on, based on that payer source and all of those things. Yes, they both connect you with those resources. Great, great. Okay, let's go back to our slide here. So we talked about the surgeon, we talked about the social worker, the different types of therapists. We said respiratory. We said respiratory. We said all things lungs, breathing, all of that. Did you talk about the nurses, the healthcare providers, the dietitian, all things nutrition, all things nutrition. We want that dietitian to come in, and remember they need those heights and weights to establish what the ideal, whether this person is within their range, out of their range, and so they can come up with a plan so that this client is offered the correct amount of nutrients. Now, that doesn't mean that they'll eat all their meals, but they have to at least be offered. So the dietitian will take into account their preferences. This person doesn't eat eggs. This person is allergic to eggs, and so forth and so on. So healthcare providers are the same discipline that work together to integrate care that will provide clients with all the services they need to maintain that safe, quality, comprehensive care. We all just working together on the team. Different educational levels. They may play an important part because the physical therapist is different from the physical therapist aide. The physical therapist is usually the person that comes in and evaluates and come up with that plan. And the PTAs, physical therapy aides, they're the ones that more than likely will carry those out. So that's just an example of those different educational roles. So each member of the interdisciplinary healthcare team they have to have that good communication. And each team member has to be able to anticipate problems, like we already know, hey, this patient's going to get therapy. Hey, just make sure that day is not Wednesday at 11 o'clock before the therapist even comes to visit the person. They need to know, hey, please give them another slot. It's more than likely going to be a problem. It seemed minimal, but it could be the difference between this client receiving the therapy and them getting that motion or movement back of that arm or leg, or them not because they're refusing, because they want to see their family member on Wednesday at 11 o'clock. Okay. This is just showing the role of the registered nurse. Just checking my time here. We are coordinating with them. We're talking with them and collaborating with them to come up, especially when they're planning for the care of that client. Because they're going to be coordinating and identifying interventions that more than likely we as LPNs will be actually implementing. So the role of the LPN, of course, we're practicing within our scope of practice. We are there to provide that best care for our clients, depending on what setting they're in. We might be the school nurse. We might be, in that industry nurse, but nevertheless, we practice within our scope of practice. So there are some expanded roles of the LPN within the long-term care facilities. You can have that charge position. That's something that you're interested in. Start that conversation early so you can start your training, your preceptor, and all of that. So yes, that is an expanded role. Long-term care facility, not acute care. Okay. So these are just different ways of how we deliver care. People just say, well, hey, let's do total patient care. ICU, we did everything for the client from A to Z, whatever it was. Bathe, fed, administer medications, whatever. Total patient care. Functional nursing is assigned to complete certain tasks. Doesn't mean that the nurse can't complete the other tasks, but each nurse is like segmented out. And then different settings have found that these different approaches help them provide best care for the people, their patients, the people of their communities. There's no wrong to it. But all of them, the end game is to provide that best care to the clients. So let's look here. Care and case management. Care coordination within a specified time frame using clinical pathways. The case manager helps patients access community resources, learn medication regimes and treatment plans, and ensures that they have recommended tests and procedures. Even if they need to be transferred to another facility, they look at and identify which facilities accept their patient's insurance, because they more than likely they're going to have to pay to stay there, them or either their insurance. So they help coordinate all of that. So client-centered, relationship-centered care philosophy, providing care that is respectful of and responsive to the individual client preferences. We've been just saying that over and over again, what they need and value, and ensuring that the client's values guide all clinical decisions. Hey, this client wants to refuse all of these interventions, it's on them, but at least we have given them enough information to make an informed decision. That's fine. Make an informed decision. Okay. So continuity of care, effective continuity of care can significantly decrease, reduce, lessen the risk of hospital readmissions. We have said that. It ensures proper follow-up. This is talking about continuity of care because we've identified, hey, this patient has to come back to see the ortho, it has to go see oncology, they have to come back and get their injections. It ensures that they understand their medications. We might have done a pill box, or the prescriptions have been called in. A lot of times when we discharge patients, we have to also talk to the pharmacists to let them know, hey, they're leaving here, and whatever their local town pharmacy is, we transfer those prescriptions to them, and so that patient can pick up those prescriptions, because a lot of times facilities don't dispense. Like, for example, if they're leaving the hospital and they're going home, they don't take medicines from the hospital. When they leave long-term care facilities, we're seeing it less and less. They don't take those medicines from there either. So, but nevertheless, we are making sure either way, even if they do or they don't, we're ensuring this client has their medications. They understand what twice a day means, once a day means, with meals. They understand all of that. This lessens the chance of this client being re-hospitalized because they understand. And more than likely, most of the time, we do what we're supposed to do, right? Most of the times. Okay. So let's look at these concepts here. Each member of the healthcare team provides a valuable service to the client. We're all valuable. All members are equally important. The nurse, the physical therapist, all of us are equally important. To understand what the LPN fits into the interprofessional healthcare team, where do we fit? We need to be aware of our educational background, our roles and responsibilities. Is this LPN, are they the charge nurse in this long-term care facility, or are they the staff nurse? So what are our roles and responsibilities? So understanding that when we talk to this person and we look at this person, we understand, okay, well, they're the charge nurse, so this is why they're asking me to do this, and this is why they're doing that, or what have you. The Institutes of Medicine, the IOM, defines a patient-centered care, providing that unique, specific care to that client. That care, making sure that it's respectful, and we include their preferences. We've been saying that off and on tonight. Okay, those are important concepts. Ineffective communication is the primary cause of sentinel events. These are events that are happening that should not be happening. It's detrimental to the patient's life, limb, or eyesight. So because something was not communicated correctly and communication means that if you're communicating to me, I understood, as well as more than you just stated it or gave me the information that I understood it. So that ineffective communication could be the difference between someone getting the incorrect medication, having surgery done on the wrong leg or limb. And so patient safety is a primary objective of handoff communication. We want to make sure if you're getting you're going home and I'm coming on, make sure that, hey, if you don't understand what the next nurse is saying, well, what do you mean? Tell me a little bit more about that. Because make sure, because there's going to be the difference in whether or not this client best care is being provided to them or not. Okay, we saved our minutes toward the end here as we usually do. So feel free to stay on if you have questions or concerns, but otherwise you're free to go. At a minimum, make sure that you are looking back at our classroom recordings, and also be looking on your exam review schedule. We posted that during that first week. So go back to the beginning of your announcements to see when we're having them. Attend them if you can. If not, make sure that you're watching those recordings. All right. Take care. We'll see you next week.